Okay, let's unpack this. You're navigating the incredibly detailed landscape of dental school, absorbing just a ton of information, right?
Definitely. It's a lot.
And you've brought us a stack of notes and excerpts from a source specifically about, well, a bacterial genus with a truly formidable reputation, Clostridium.
That's right. Yeah, when most people hear Clostridium, they probably think of some pretty scary diseases, tetanus, botulism, gas gangrene. It's a group known for packing a punch with powerful toxins.
Right. And you're sitting there thinking, okay, scary bacteria, but why does this specific genus need to be on my radar as a future dentist? That's sort of our mission in this deep dive, using only the material you've shared from the source, Clostridium, morphology, pathogenesis, diagnosis, treatment, and dentistry. We're going to try and cut through the density of the information and extract the most important nuggets, filtering everything through the lens of your world in dentistry.
Exactly. Think of this as your personalized guide, sort of, to understanding why Clostridium, despite not being your everyday cavity-causing bug, is actually relevant to several critical areas you will face in practice.
Things like?
Like diagnosing tricky symptoms, making smart antibiotic choices, and absolutely crucial, ensuring your clinic environment is safe.
Yeah, this isn't just, abstract microbiology. This is about connecting dots, understanding the fundamental science of these organisms so you can appreciate its very real, practical implications for patient care and safety. We're going to explore what these bacteria are, what makes them unique, the big diseases they cause, how they're identified and treated, and most importantly, how every piece of that puzzle ties back directly to the dental chair.
Let's dive in then.
All right, let's start with the absolute basics from the source material. What is Clostridium fundamentally as a group of bacteria?
Okay, so the source describes Clostridium as a genus, right? A diverse group within the bacterial kingdom. And there are a few characteristics that immediately set them apart.
Like what?
Well, the first is their Gram-stain reaction. They're typically gram-positive. And this tells us something fundamental about their cell wall structure.
Okay, gram-positive. Standard stuff.
Well, yes, but the source points out a detail that can sometimes trip you up in the lab. Older cultures might stain less predictably. Sometimes they can look gram-variable or even gram-negative.
Ah, okay. So a little quirk there.
Yeah, it's a small detail, but, useful to remember if you're ever looking at a less than perfect slide.
So gram-positive, but with a caveat for older cells. What's another defining trait?
This is arguably their most clinically significant feature, and it's key to understanding why they can be such persistent environmental contaminants and problematic in certain infections. They are obligate anaerobes.
Obligate anaerobes, meaning no oxygen allowed. Right, they hate it.
Precisely. They cannot grow or even really survive for long if there's oxygen around. This is a critical distinction from, say, facultative bacteria you might encounter, which can grow with or without oxygen.
Yeah.
This strict requirement for oxygen-free environments dictates where these bacteria are going to thrive, in the body or the environment.
And the source also mentions they are bacilli, rod-shaped.
Yes, they are rod-shaped bacteria. So put it together. Gram-positive, mostly, rod-shaped, and absolutely requiring an anaerobic environment. But there's one more defining feature you mentioned earlier. Something that makes them incredibly hardy.
The spores, endospores.
Yes. The ability to form endospores. This is perhaps the single most important characteristic from an infection control perspective, as we'll definitely get to later.
Right.
These are not reproductive spores like you'd see in fungi. They are survival structures. Basically, when conditions become unfavorable, like lack of nutrients, presence of oxygen, temperature changes, the bacterial cell can transform into this dormant, incredibly resilient spore.
How tough are we talking? Like, really tough.
Oh, incredibly tough. The source tells us they're resistant to heat, drying, radiation, and many chemical disinfectants. This is why Clostridium spores can just hang out in soil or dust for years.
Wow. Okay.
And then, when they find themselves in a favorable anaerobic environment again, they can germinate back into the active vegetative bacterial cell, ready to grow and, crucially, produce toxins.
That resilience, that's a game changer for how we have to deal with them in, say, a clinical setting.
Absolutely.
So where do these tough, oxygen-hating, spore-forming rods hang out normally? The source painted a picture of their natural habitat.
Yeah, they're basically everywhere in the environment. The source lists soil, water, sewage, and areas rich in decomposed organic matter, both animal and plant. They're quite literally part of the natural recycling system in anaerobic environments.
So they're common environmental bacteria. Does that mean they're always causing problems? Or are some harmless?
Not at all, and the source makes this clear. Many Clostridium species are just harmless saprophytes living on dead organic stuff. They don't cause disease in living things.
Okay.
However, within this large genus, there are a few species that possess the genetic machinery to produce these potent toxins, and those are the ones responsible for serious human diseases.
Okay, so a few bad apples in a large barrel of generally harmless environmental bacteria. Got it. Now let's get visual. What does the source tell us about their morphology, what they actually look like under a microscope, especially because of those spores?
Right. This is where their name becomes quite descriptive. The source describes them as large rods, typically 3 to 8 micrometers long and maybe 0.4 to 1.2 micrometers wide, usually straight or slightly curved with rounded ends.
Pretty standard rod shape then. But the spore, how does that change the look?
This is the key visual identifier for many of them. The source emphasizes that the endospore, when it forms, is usually wider than the bacterial rod itself.
Wider than the cell body?
Yeah. So when the spore forms within the rod, this creates a characteristic swelling. If the spore is located centrally or subterminally, near the end, this swelling gives the bacterium a kind of spindle-like shape.
Ah, the cluster, the spindle. That's where the name Clostridium comes from.
Exactly. The name literally means spindle, so seeing that visual cue under the microscope is often the first hint you might be dealing with this genus.
Are they always that perfect spindle shape, though? Or can they vary?
Good question. The source notes they can show pleomorphism, meaning they can vary in shape, especially in older cultures or maybe under unfavorable conditions. You might see longer filaments or kind of irregular forms sometimes.
Okay. What about movement? Can they, swim around?
Most Clostridium species are modal, yeah. They use peritrichous flagella, those whip-like things all over the cell surface that let them propel themselves through their environment.
Most, but not all.
Right. The source specifically calls out exceptions. Clostridium perfringens and Clostridium tetani type VI are listed as non-modal.
Interesting. C. perfringens, again, seems to be an exception. Any other external coats, like capsules? Are they usually encapsulated?
Most like capsules, actually. But again, C. perfringens and another one, Clostridium butyricum, are exceptions. They do possess a capsule.
C. perfringens really is a bit of an outlier morphologically, isn't it?
It seems so, yeah.
Are there any other really distinctive shapes to look for besides the spindle?
Oh, definitely. One is very famous and directly linked to a major disease. The source describes the characteristic drumstick appearance of Clostridium tetani.
The tetanus bug.
That's the one. This shape is due to the spore forming right at the very end of the rod, the terminal end. And it causes that end to swell up significantly, looking just like a drumstick or sometimes people say a tennis racket.
Wow.
Seeing that specific shape under the microscope is a really strong presumptive indicator of C. tetani.
The tetanus drumstick, that's a memorable image. And C. perfringens, you mentioned it's large and rectangular.
Yeah, the source describes C. perfringens as a large bacillus, maybe 4 to 6 micrometers long, with characteristically parallel sides and rounded or maybe truncated ends. It's more boxy, definitely, than the spindle or drumstick shapes.
Okay, so we've got these hardy, anaerobic, spore-forming rods found widely in the environment, often recognized by their spindle or drumstick shape, or as large rectangles in the case of C. perfringens. Now, let's transition to the main reason we're talking about them, their ability to cause some really serious diseases. The source goes into pathogenesis. How do they actually make people sick?
Well, the source highlights 2 primary mechanisms, really. First, their production of potent toxins. These are often the main drivers of the disease symptoms.
Okay, toxins.
And second, their ability to survive as those incredibly tough spores until they find just the right anaerobic conditions to germinate and grow.
The toxins are key, though, you said. What kinds of toxins do they make?
The source mentions several types. Neurotoxins that mess with the nervous system, enterotoxins that affect the gut, and histolytic toxins that actually damage tissues directly. The specific type of toxin really determines the kind of disease they cause.
And the spores allow them to get into the body and just wait.
Exactly. A spore might get into a wound from contaminated soil, for example. If that wound becomes deep, maybe dirty, has poor blood supply, basically, conditions that create an anaerobic environment that spore can germinate into a vegetative cell. And then it starts multiplying and producing toxin.
Ah, okay, that makes sense. The source then focuses on the big 4 diseases associated with Clostridium. Let's start with tetanus, caused by Clostridium tetani.
Right. Tetanus is a classic example of a purely toxin-mediated disease. The bacterium itself usually stays localized, like right at the site of entry, maybe a wound. The problem is the incredibly potent neurotoxin it produces, called tetanospasmin.
Tetanospasmin. Okay, what does this toxin do in the body?
According to the source, tetanospasmin is a heat labile toxin. It's produced at the wound site and then it travels up the nerves to the central nervous system. Specifically, it targets inhibitory synapses in the spinal cord.
Inhibitory synapses, so it stops the stop signals.
Exactly. Its action is to block the release of inhibitory neurotransmitters, like GABA and glycine. Normally, these signals help regulate muscle contractions, allowing muscles to relax after they contract.
Oh, yeah.
But when tetanospasmin blocks these signals, the excitatory signals from the brain just go unopposed. And that leads to continuous, severe muscle spasms.
And this is where the dental relevance really clicks in, right? The source highlights specific clinical manifestations.
Absolutely. The source emphasizes that spasm of the jaw muscles, known as lockjaw or trismus, is an early and hallmark symptom of tetanus.
Trismus. Can't open the mouth.
Right. And this is incredibly relevant for you as a future dentist, because patients often present to dental clinics complaining they can't open their mouth properly. Now, while trismus has many causes, TMJ issues, local infections, muzzle strain, you must include tetanus in your differential diagnosis, especially if the patient has a history of a recent wound and maybe inadequate immunization.
Wow. So trismus isn't just a dental issue. It can be a red flag for a really serious systemic disease like tetanus. That's a crucial connection for you to make.
Definitely.
What are other tetanus symptoms the source mentions, besides the lockjaw?
Facial spasms, sometimes described as rhizus sardonicus, which is like a fixed, weird grin, and then more severe generalized spasms leading to arching of the back, known as opisthotonos. But really, trismus is the one that will most directly make a patient seek dental care first.
Okay. The source also mentioned another toxin from C. tetani, tetanolysin. Does that do much?
Yeah, the source mentions tetanolysin. It's an oxygen-labile hemolysin, meaning it can damage red blood cells.
Yep.
However, the source notes that its clinical significance isn't really well defined compared to the devastating effects of tetanospasmin.
So tetanospasmin is the main player.
Yeah, for practical purposes, the neurotoxin is the focus for understanding tetanus disease. It's also mentioned that the genes for these toxins are plasmid-coded, meaning they are on these mobile genetic elements within the bacteria, not necessarily the main chromosome.
Interesting. Okay, so tetanus is a neurotoxin causing spasms, with trismus being a key symptom for dentists to recognize. Next up, gas gangrene, also called myonecrosis. This one sounds incredibly destructive just from the name.
Oh, it is. Gas gangrene is a severe, rapidly spreading infection of muscle tissue. It's often life-threatening and typically requires pretty drastic surgical intervention, like excision or even amputation sometimes.
Yikes. And who's the main culprit here?
It's primarily caused by Clostridium perfringens, though other Clostridium species like C. novii and C. septicum can also be involved sometimes.
How does it develop? Like, where does it start?
It occurs in damaged, devitalized, or poorly oxygenated tissues. So think severe trauma, maybe surgical sites with poor blood supply, or deep puncture wounds. These anaerobic conditions are just perfect for Clostridia spores to germinate.
And once they start growing?
They produce a whole barrage of toxins and enzymes.
And the main culprit, C. perfringens type A, has a key toxin here. What's that called?
Yes, the source highlights alpha toxin as crucial for C. perfringens. It's a lecithinase.
Lecithin.
Yeah, it's an enzyme that breaks down lecithin, which is a major component of cell membranes. So its action damages cell membranes extensively. This causes cell death, widespread tissue destruction, and toxemia as the toxins spread through the body. It also increases vascular permeability, which just fuels the rapid spread.
So it's actively dissolving tissue.
Wow.
And the gas, that's part of the name, gas gangrene.
Right, the gas comes from the fermentation of carbohydrates in the tissues by the bacteria. This produces gas, like hydrogen and carbon dioxide, within the tissue planes.
You can feel it.
Yes, the source notes this gas causes crepitation, that crackling or crunching sensation you can feel under the skin when you palpate the affected area. And this gas production isn't just a symptom, it actually helps the infection spread by physically dissecting through tissue layers.
Toxin dissolving tissue and gas pushing the infection forward. That's a terrible combination. The source also noted that these are often mixed infections, not just Clostridium.
Yes, almost always polymicrobial. Clostridium species are usually present along with other anaerobic bacteria and often facultative organisms too. The source also mentions a less severe condition, anaerobic cellulitis, also caused by C. perfringens, where there is gas in the soft tissues, but without the deep muscle invasion you see in myonecrosis.
Okay. Gas gangrene, while rare, really underscores the importance of managing deep wounds and surgical sites properly to prevent creating those anaerobic environments where these guys can thrive. Moving on to botulism.
Botulism, caused by Clostridium botulinum, is thankfully rare, but it is a severe paralytic illness. Unlike tetanus, which causes spastic paralysis, the rigid muscles, botulism causes flaccid paralysis.
Flaccid, meaning weak, floppy.
Exactly, muscle weakness and loss of tone.
And it's toxin-mediated, too, like tetanus, another neurotoxin.
Yes, caused by the incredibly potent botulinum toxin, another neurotoxin, but its mechanism is different. While tetanospasmin blocks inhibitory signals, botulinum toxin blocks the release of excitatory signals, specifically acetylcholine, right at the neuromuscular junction.
So it stops the nerve signal from actually reaching the muscle to tell it to contract.
Precisely. The muscle never gets the signal to contract, leading to weakness and paralysis. The source describes three main forms: foodborne botulism, from ingesting preformed toxin in contaminated food, often improperly canned stuff.
Right, the classic canning risk.
Exactly. Then there's wound botulism, where spores get into a wound, germinate, and produce toxin right there. And infant botulism, where infants ingest spores, maybe from honey or environmental dust, and those spores colonize their immature gut and produce toxin there.
Okay, so botulism is paralysis, often starting from ingesting the toxin or spores. Finally, Clostridium difficile infection. This is one you hear about much more frequently these days, especially in healthcare settings.
Yes, C. difficile, often called C. diff, is the cause of antibiotic-associated diarrhea and colitis, and it can range from mild diarrhea to the really severe form known as pseudomembranous colitis, which can be life-threatening.
And the name gives away the cause, antibiotics. How does that work?
The source explains this really well. C. difficile can actually be part of the normal gut flora in a small percentage of healthy people. It just sits there, not causing problems usually.
Okay.
The problem starts when a patient takes antibiotics. These drugs suppress the normal, sensitive bacteria in the gut, the ones that are usually keeping C. difficile in check through competition.
Ah, so antibiotics clear the way.
Exactly. C. difficile is often resistant to many common antibiotics, so it suddenly faces much less competition. This allows it to multiply unchecked, to really proliferate in the gut.
Which antibiotics are often the culprits, according to the source? The ones dentists might use?
Yeah, this is key. The source specifically names clindamycin, cephalosporins, and ampicillin as examples of antibiotics commonly associated with triggering C. difficile infection because of their impact on gut flora. And these are definitely drugs used in dentistry.
That is a crucial point for your antibiotic prescribing decisions in the future. Absolutely.
Definitely. And once C. difficile proliferates, it produces toxins. The source notes two main ones. Toxin A, which is an enterotoxin that initially causes fluid secretion and diarrhea.
The diarrheal part?
Right. And toxin B, which is a much more potent cytotoxin. It directly damages the cells lining the colon, leading to inflammation and the formation of those characteristic pseudomembranes you see in severe colitis.
And outbreaks are common in hospitals and places like that?
Yeah, the source mentioned C. difficile infection is a common healthcare-associated infection, frequently reported in hospitals and long-term care facilities, precisely because of the high rate of antibiotic use in those settings. It's a major issue.
Okay. So, tetanus, spastic paralysis trismus, gas gangrene, tissue destruction longus, botulism, flaccid paralysis, and C. difficile antibiotic-induced diarrhea colitis are the main disease pictures we need to keep in mind. Now, how do labs actually diagnose these infections, especially given that Clostridia are so picky about oxygen? It sounds tricky.
It is, yeah. Diagnosis requires specific methods because of their anaerobic nature, and also because some diseases are primarily toxin-mediated, not just about finding the bacteria. The source outlines the key steps.
First step has to be getting the right sample, I assume.
Absolutely. Specimen collection is critical, and it really depends on the suspected infection. You might need pus from a wound, tissue from suspected gas gangrene, maybe blood for systemic infection, or feces for C. difficile or foodborne botulism.
What about contamination, like from skin bacteria?
A big issue. For samples that normally contain lots of other bacteria, like feces, the source says selective media are used. These help isolate the Clostridium species from all the background noise, essentially suppressing the other bacteria. And careful collection technique is paramount to avoid contaminating the sample with normal flora from surrounding sites, which could really interfere with the lab's ability to find the specific pathogen.
Makes sense. So you get the sample carefully. Once it's in the lab, what's the first look?
Microscopy. Usually, yeah. Microscopy, typically using gram staining. You'd be looking for those gram-positive rods, but always keeping in mind that variability we talked about in older cultures.
And looking for those distinctive shapes you mentioned before, the spores.
Yes. The presence and morphology of spores are key clues. Seeing those terminal spores creating the drumstick shape is highly suggestive of C. tetani.
Oh.
And for suspected gas gangrene, the source gives a very important kind of counterintuitive microscopic finding.
Yeah.
A large number of large gram-positive rods, likely C. perfringens, that surprisingly lack visible spores in the tissue sample.
No spores, but they form spores.
Right, but maybe they're growing so fast they haven't formed them yet in the act of infection. And alongside the bacteria, you see a notable absence of leukocytes, pus cells, white blood cells.
Wow. Lots of bacteria, but no inflammatory cells. That is counterintuitive. Why?
Exactly. It suggests the toxins are perhaps so potent they're killing the immune cells right there. Or maybe the bacteria are growing so incredibly fast the immune response just can't keep up locally. It's a strong clue for gas gangrene.
That's fascinating. What about C. botulinum?
For C. botulinum, gram-stain smears from relevant samples might show gram-positive spore-bearing rods. But microscopy alone isn't really diagnostic for botulism. It's more suggestive.
Okay, so microscopy gives clues, but growing them, culturing them, must be the definitive step, which sounds really hard for these anaerobes.
It's the major hurdle. The source really hammers this home. They are obligate anaerobes, extremely sensitive to oxygen. So culturing them requires creating and maintaining strictly anaerobic conditions. No oxygen allowed.
How do labs actually do that, like practically?
They use things like anaerobic jars or special anaerobic chambers or bags that actively remove oxygen or maintain an oxygen-free atmosphere. The source notes they can grow on enriched media like blood agar or media specifically designed to be reduced, meaning low oxygen.
Right.
Like a Robertson's cooked meat medium, CMB, or thioglycolate broth. CMB contains meat particles that help absorb oxygen, and thioglycolate media has a reducing agent chemically removing oxygen.
How long do they need to incubate?
Typically 37 degrees Celsius for maybe 1 to 2 days, though the source notes some anaerobes might take longer, maybe 5 to 7 days sometimes.
And when they grow on the culture plate, is there anything distinctive to look for? Any visual clues?
Yes, definitely, especially for C. perfringens. The source mentions C. tetani can show kind of a swarming motility spreading across the agar, but C. perfringens grows rapidly and produces a very characteristic double zone of hemolysis on blood agar.
Double zone? What's that look like?
It's a clear zone of complete red blood cell destruction, lysis, immediately around the colony, and that's surrounded by a wider, hazier zone of partial lysis. If you see that double zone, C. perfringens should jump right to mind.
A visual signature. That's cool. After growing them, how do they identify the specific species? Is it just the colony look?
No, they use biochemical tests too. These tests look at the bacteria's ability to ferment different sugars if they're saccharolytic or break down proteins if they're proteolytic.
How does that show up?
Well, the source mentions this affects how they grow in that cooked meat medium. Proteolytic species might turn the meat black and produce foul odors, while saccharolytic ones cause acid production, maybe turn it pinkish.
Are there any really quick specific tests for certain species that are important?
Yes, the source highlights 2 classic tests specifically for C. perfringens. First is the Nagler reaction.
Nagler?
Yeah, it detects the alpha toxins lecithinase activity. You grow the bacteria on egg yolk agar, which is rich in lecithin. C. perfringens colonies will be surrounded by a zone of opalescence, like a cloudy opaque area, because its alpha toxin is breaking down the lecithin in the agar.
Opalescence on egg yolk agar. Nagler positive means likely C. perfringens. Got it.
What's the other one? The other is stormy fermentation in litmus milk. C. perfringens ferments lactose really vigorously, producing tons of acid and gas. This causes the milk medium to clot, and then the gas bubbles literally tear the clot apart, creating this turbulent, stormy appearance in the tube.
Nagler reaction and stormy fermentation specific and memorable tests for C. perfringens. Okay. Beyond identifying the bacteria themselves, what about detecting the toxins? Since those are so important for diseases like tetanus and botulism.
Right, for those diseases where the toxin is the primary problem, toxin detection is crucial. The source mentions the historical method, the 2 mouse model.
Injecting mice.
Yeah, basically. Samples were injected into mice. Sometimes one mouse also got antitoxin to see if it neutralized the effects. It was a functional assay for toxin activity.
Sounds cumbersome. Are there modern methods?
Oh, yes. The source notes that immunological methods like ELISA, enzyme-linked immunosorbent assay, and molecular methods like PCR are now commonly used for direct toxin detection, particularly for C. botulinum toxins in food or fecal samples, much faster and avoids animal use.
And for C. difficile, how is that diagnosed? Is it the bacteria or the toxin?
It's usually toxin detection in fecal samples. That's the standard for C. difficile diagnosis. The source mentions older methods like looking for toxin B's cytopathic effect on cultured cells, but more commonly now it's immunological assays like ELISA used to detect toxin A and/or toxin B directly in the patient's stool sample.
Okay, so diagnosis really relies on carefully collected specimens, microscopy for those initial clues like shapes, spore presence or absence, that weird lack of leukocytes and gas gangrene, then culturing in strict anaerobic conditions, using biochemical tests and specific reactions like Nagler and Stormy fermentation for identification, and critically, toxin detection for the toxin-mediated diseases. That's a pretty comprehensive lab picture.
It really shows just how specialized the lab work has to be for these particular organisms. They're not routine cultures.
So once a Clostridium infection is diagnosed, how is it treated? What are the approaches?
Well, treatment varies significantly depending on the specific disease, as you'd expect. But the general approach often involves a combination of things. Antibiotics to kill the bacteria, maybe antitoxins to neutralize circulating toxins if it's a toxin disease, and definitely supportive care.
Let's touch on general antibiotic sensitivity first, because this directly impacts prescribing, especially for you as a future dentist dealing with potential anaerobic infections. What works?
The source gives us a useful overview of Clostridia's general susceptibility profile. They are generally susceptible to several common antibiotics. Metronidazole is a big one, also penicillin and cephalosporins. This means these are often good choices if you need to target Clostridia or anaerobic infections more broadly.
Okay, metronidazole, penicillin, cephalosporins, good options. What about less effective options?
They're noted as being less sensitive to tetracyclines.
And resistant. Anything they just laugh off.
The source states they are generally resistant to quinolones, like Cipro, and aminoglycosides, like gentamicin. So you wouldn't want to rely on those classes if you suspect a clostridial infection. This sensitivity profile is a really key piece of information when you're selecting an antibiotic.
Knowing which classes work and which definitely don't is essential. Okay, now, drilling down. Specific treatments for the major diseases. What about tetanus?
For tetanus, the focus is really twofold. Neutralize the toxin that's still circulating and support the patient through the spasms. The source says antitoxin is given, typically human tetanus immunoglobulin, or TIG. This provides ready-made antibodies to bind and neutralize any tetanospasmin that hadn't yet attached to nerve tissue.
But what about the bacteria still making the toxin?
Critical point. Proper wound debridement and meticulously cleaning and removing all dead or devitalized tissue from the wound is absolutely essential. You have to eliminate the site where the bacteria are actively growing and producing the toxin. Get rid of their anaerobic home.
Antibiotics are also used too, right?
Yes. Penicillin or metronidazole is usually given. The goal there is to kill the vegetative C, to tiny cells still in the wound, stop further toxin production, and also prevent secondary bacterial infections. But it's crucial to remember, antibiotics don't fix the neurological effects of the toxin that's already bound to the nerves. That damage is done.
Which is why prevention is obviously way better than treatment here.
Absolutely. The source highlights active immunization with the tetanus toxoid vaccine as the primary preventive measure. That's the shot you get, usually in childhood as part of DTP or similar vaccines, and then boosted periodically, typically every 10 years. This trains your body to make its own antibodies against the toxin.
Okay. Moving to gas gangrene treatment. You said this sounds like a surgical emergency.
It absolutely is. The source emphasizes that management is primarily surgical. Prompt and extensive debridement, maybe even amputation of the infected limb or tissue, is often necessary. You have to remove the anaerobic environment and the bulk of the bacteria and their toxins physically.
Aggressive surgery and antibiotics.
Yes, high-dose antibiotics, often penicillin or metronidazole, are used in conjunction with surgery. They target the bacteria in the surrounding tissues and potentially in the bloodstream.
Supportive care is also important, I imagine.
Definitely. Managing shock and fluid balance is crucial. The source also mentions that hyperbaric oxygen therapy might be beneficial.
Putting the patient in a high-pressure oxygen chamber.
Exactly. This increases the oxygen concentration in the tissues, which makes it less hospitable for these obligately anaerobic Clostridia. It might help inhibit their growth and toxin production.
Using high oxygen to fight the oxygen haters makes perfect sense. Okay, botulism treatment. What's the focus there?
For botulism, treatment focuses on supporting respiration because of the paralysis and neutralizing any circulating toxin. The source says polyvalent antitoxin is administered. This helps neutralize the botulinum toxin that hasn't yet bound to nerve endings.
Do they try to eliminate the bacteria too?
Yes, if the organism is thought to be present in the gut, like in foodborne or infant botulism, gastric lavage might be performed to wash it out. And antibiotics like metronidazole or penicillin may be used to try and eliminate the bacterial source of the toxin from the gut or a wound.
And support for the paralysis itself?
This is arguably the most critical aspect of care. The source stresses the absolute necessity of adequate ventilatory support. Because the paralysis can affect the respiratory muscles, patients often need mechanical ventilation to keep breathing until the nerve function recovers, which can take weeks or months.
Wow. Okay. Finally, treatment for C. difficile infection, the antibiotic-associated one.
Right. The first, and often the most important step highlighted by the source, is simply discontinuing the antibiotic that triggered the infection as possible. This allows the normal gut flora a chance to start recovering and compete with the C. difficile.
Sometimes just stopping the offending antibiotic is enough.
Sometimes, for milder cases. But if that's not enough, or if the infection is severe, then specific antibiotics that are effective against C. difficile itself are used orally. The source lists oral metronidazole or oral vancomycin. These target C. difficile right there in the gut lumen to suppress its growth and toxin production. Vancomycin often stays in the gut, which is good for this purpose.
Okay, so treatment strategies really range from aggressive surgery for gas gangrene to toxin neutralization and support for tetanus and botulism and antibiotic adjustments and targeted gut antibiotics for C. difficile, all supported by general medical care, of course.
Yeah, it's a diverse set of responses really tailored to the different ways these different species cause disease.
Now, for the really crucial part for you, our listener, connecting all of this detailed information about a genus known mostly for systemic and environmental diseases back to your world as a dental student and future practitioner. The epilogue section of your source material makes several direct links that make all this info incredibly relevant.
Yeah, this is where we put on our dental magnifying glass, so to speak. While Clostridia aren't typically considered part of the normal, healthy oral microflora in large numbers, their potential presence, their toxins, and the implications of dealing with anaerobic environments and antibiotic use are highly relevant to dentistry.
Let's go through the points the source makes about dentistry. First, oral infections. How do Clostridia play in there?
Well, the most direct connection is back to tetanus and trismus. Remember lockjaw?
Can't open the mouth.
Right. As we discussed, trismus is a cardinal sign of tetanus. You will encounter patients with trismus in your career. The source makes it clear you need to include tetanus in your differential diagnosis, especially if there's a history of trauma or a wound. Now, obviously, most cases of trismus are due to less severe causes, but failing to consider tetanus when it's appropriate could have life-threatening consequences.
So seeing trismus isn't just a mechanical problem to fix, it's a prompt to think systemically, ask about recent injuries, immunization status.
Exactly. You have to be a detective, asking the right questions about their medical history. And related to that, the source notes that proper wound debridement of any oral or cervicofacial injuries is relevant to preventing tetanus. Dental procedures themselves can create wounds.
So good surgical technique and wound care matter, even beyond just healing.
Yes. While tetanus from a simple dental extraction is exceedingly rare, understanding the importance of wound care in reducing anaerobic environments is fundamental, especially if you're dealing with traumatic injuries involving the mouth and face.
Okay. What about the common infections you'll deal with all the time, like tooth abscesses, periapical infections, periodontal abscesses? Are Clostridium species involved there?
That's a really good question, and the source addresses this nuanced point. It acknowledges that dental-alveolar infections, like abscesses, are typically polymicrobial and dominated by strict anaerobes, the usual suspects like Prevotella, Porphyromonas, Fusobacteria.
Right.
However, it specifically states that Clostridium species are not listed as predominant isolates in these routine run-of-the-mill dental infections.
Okay, so not the usual suspects in a typical tooth abscess.
Correct. But, and this is important, the source adds a crucial caveat. They could potentially be part of the complex mix of bacteria in severe cases, particularly if the infection spreads beyond the tooth socket into deeper tissues or fascial spaces in the head and neck.
Why there?
Because those deeper spaces are more strictly anaerobic environments, much less oxygen. That's where Clostridia might find ideal conditions to thrive if they get seated there. So while they're not the norm in a simple abscess, they are a potential contributor you should be aware of in really serious spreading anaerobic odontogenic infections.
Okay, so rare in a simple abscess, but potentially lurking in a severe spreading deep space infection, something to keep in the back of your mind for complex cases. The source also mentions fusospirochetal infections like ANU. What's the Clostridium connection there?
Ah, right. The source notes that metronidazole, remember, An antibiotic effective against Clostridia is also effective against these infections, acute necrotizing ulcerative gingivitis and Vincent's angina. These are caused by other anaerobes like Fusobacterium and Treponema vintentii.
So Clostridium doesn't cause ANUG.
Correct. The source clarifies that Clostridium is not part of that specific fusospirochetal complex. The point here seems to be more about highlighting that metronidazole is a good drug choice for anaerobic infections in general, including some important oral ones, while also reinforcing that it works against Clostridia if they were present. It's about understanding the spectrum of your antibiotics.
Got it. So metronidazole is a good anaerobic fighter overall, useful for things dentists see regularly, but Clostridium isn't the specific bug behind ANU itself. Makes sense.
Yeah.
What about general wound infections after dental surgery? Like, could you get gas gangrene from an extraction?
This goes back to those ubiquitous spores we talked about. Dental surgical procedures create wounds, right? The source reminds us that Clostridium spores are literally everywhere in the environment. Soil, dust, even potentially on contaminated surfaces if infection control isn't perfect. While it's very rare, the source implies there is a theoretical risk that if these spores get into a deep, poorly oxygenated surgical site, maybe a poorly healing extraction socket with a blood clot, they could germinate and cause a severe clostridial wound infection, like gas gangrene.
So while gas gangrene from routine dental surgery is almost unheard of in modern practice with good technique, the mere possibility, the existence of these spores, reinforces the importance of meticulous surgical technique. Things like good hemostasis to prevent hematomas, which can become anaerobic, and proper wound management.
Absolutely. It underlines why we have such stringent protocols even for what seem like simple procedures. We are working in an environment where these incredibly resilient pathogens could be present as spores, even if the risk of them causing disease is low. It's about minimizing that risk.
Okay, that's a really practical point. This leads perfectly into the second major implication the source highlights for dentists: antibiotics stewardship.
Yes, this is huge EE for dentists. You will be prescribing antibiotics frequently throughout your career. The source makes it unequivocally clear that awareness of Clostridium difficile infection as a serious complication of antibiotic therapy is critical knowledge for every single dentist.
Why is this so important for a dentist specifically? We don't treat gut infections.
No, but you prescribe the drugs that can cause them. As we discussed, many antibiotics commonly prescribed in dentistry can significantly disrupt the normal gut flora, paving the way for C. difficile overgrowth.
And the source names some specific ones.
Yes, it specifically called out clindamycin, ampicillin, and cephalosporins. These are workhorse antibiotics in dentistry, often used for odontogenic infections. You absolutely need to know that prescribing these carries a risk, potentially a serious one, of your patient developing C. difficile-associated diarrhea or colitis, maybe days or even weeks later.
So this knowledge directly influences your antibiotic selection process and also how you counsel your patients.
Precisely. When you're choosing an antibiotic, you're not just thinking, will this kill the oral bug? You also need to consider the potential systemic impact and risks, including C. difficile. And if you do prescribe one of these higher risk drugs, you should advise your patient about the symptoms, tell them to contact you or their physician if they develop severe or persistent diarrhea after taking the antibiotic.
That's a direct line from understanding bacterial ecology in the gut to making a safe clinical prescribing decision in your dental office.
Wow. What's the final major implication the source brings up for dentistry?
Infection control. This is where the whole spore-forming ability of Clostridium really comes into sharp focus for dental practice. The source strongly emphasizes the necessity of stringent infection control, particularly regarding sterilization of instruments.
Because of the spore's toughness. Regular disinfection isn't enough. Exactly. Those spores are resistant to many chemical disinfectants. The source highlights that sterilization methods must be effective against bacterial spores. This is why autoclaving, using high heat and pressure steam, is the absolute standard of care for critical dental instruments.
Critical instruments being?
Those that penetrate soft tissue or contact bone or the bloodstream. Things like surgical instruments, periodontal scalers, endodontic files. Autoclaves use conditions capable of killing even the most resilient bacterial spores, including Clostridium spores.
So autoclaving isn't just about killing everyday bacteria and viruses. It's specifically mandated, in large part because of the need to eliminate these incredibly tough spore formers that might potentially be present on instruments.
That's the core insight the source provides here. The resilience of Clostridium spores sets a very high benchmark for what constitutes effective sterilization in healthcare. And even for disinfectants used on surfaces or non-critical items, the source implies they should ideally be sporicidal, or at least high-level disinfectants, to provide a broad spectrum of activity that accounts for potential environmental contaminants, including these resilient spores.
It connects back to every single instrument you use, every surface you touch in the clinic, proper reprocessing, following the protocols exactly. It's completely non-negotiable.
It absolutely is. The source ties this back to the general principles. Proper instrument reprocessing and environmental disinfection protocols are vital for preventing the transmission of a wide range of pathogens, and that includes being prepared for potential Clostridium spores that could be introduced from the environment or even theoretically from a patient. Their existence reinforces the need for the highest standards of infection control, always.
Okay, let's bring this all together then. For you, the dental student, absorbing all this, based on this deep dive into your source material, how does understanding this genus, Clostridium, actually shape your future practice? What are the key takeaways?
Well, I think this knowledge fundamentally enhances your clinical acumen, your thinking. It expands your differential diagnosis. When you see a patient presenting with something like trismus, you won't just think PMJ.
Right.
It makes you a more informed and, frankly, more cautious prescriber when choosing antibiotics because you're acutely aware of the downstream risk of C. difficile.
That's a big word.
And it provides the scientific why behind those essential safety protocols you're learning.
It helps you understand why they're important.
Exactly.
Yeah.
It helps you truly understand and appreciate why those stringent infection control protocols, especially spore-killing sterilization techniques like autoclaving, are not just bureaucratic rules you have to follow. They are essential measures, scientifically grounded in protecting your patients from potential, sometimes unexpected threats like these hardy spores.
And ultimately, maybe it gives you a deeper respect for the complex microbial world you'll be working within, even in the mouth.
I think so. It shows how organisms known primarily for causing these dramatic systemic diseases can still have specific, practical, and sometimes subtle points of contact with everyday dental practice. It just emphasizes the need for ongoing vigilance and continuous learning.
Yeah, understanding the capabilities of even these less common dental bugs or potential contaminants like Clostridium definitely makes you a more comprehensive and safer practitioner in the long run.
Definitely.
This deep dive really highlighted that microbiology isn't just something you learn for an exam and then forget. It's absolutely foundational to your clinical decision-making and patient safety every single day. It's clear that even a genus like Clostridium, known for diseases often far from the mouth, really does require your attention.
Indeed. The sheer toughness and the widespread presence of Clostridium spores just out there in our environment, they serve as this constant, silent reminder of the microscopic challenges we face in healthcare, including dentistry.
So perhaps the final thought to leave you with, mulling over the source material, is this. How does the very existence of such resilient, often toxin-producing organisms that are constantly present around us as dormant spores, how does that underscore the profound responsibility you have as a future healthcare provider to maintain the absolute highest standards of knowledge, technique, and safety in your practice, recognizing that even the rarest threat requires diligent, everyday prevention?
It's a powerful thought. Staying ever informed and ever vigilant really is our most potent defense against challenges like these.
Thank you for bringing these fascinating sources for this deep dive. It's been incredibly insightful connecting Clostridium to the world of dentistry.